Today we will do the knee joint. Like the joint knee joint starts with the weight being there. When we stand over the weight falls on the joint and femur and then it falls on the knee joint. So knee joint will be described under the headings of number 1, bone segment part. Then the attachment of the fibrous capsule. Then various ligaments, various movements of the knee joint, and last of all the applied activity. So we will take one by one. First we will take what are the bones which are taking part in the joint formation. As we know, the lower end of the femur and upper end of the tibia, they form the joint, plus one joint is also formed between the patella and the femur. So, it is a complex joint formed by the condyle or synovial, and it is the largest synovial joint of the human body. And maximum amount of this synovial fluid is present in this. And how much amount it is? 2 ml. So first we will take the bone joint formation. And first is the lower end of the femur bones and tibia and patella. So you should have a three-dimensional picture in mind that while we are studying the knee joint. So when we see the knee joint, the lower end of the femur, the posterior view of the lower end of the femur, similarly, the upper end of the tibia of the knee joint, when we see the posterior part, it coincides with the lateral condyle, the femur, and laterally they will have a fibula from the superior tibiofibular joint, and on the posterior surface shaft of the tibia there is a oblique line on the spiral line, on the soleal line, right? So this is how we see the knee joint from the posterior aspect. And when we see the knee joint anteriorly, and another is when we see the knee joint laterally. this is the lining of the skin. So bone taking part, as you know, it is the lower level of the femur with all the features, the upper end of the tibia with all the features. Fibula is not taking part of the knee joint. So this is the three-dimensional picture. Now the second part comes from the knee joint is the attachment of the fibrous structure. So fibrous structure is attached superiorly. If we see the anterior aspect, it is attached to the lateral epicondyle, superior surface of the lateral epicondyle. When it descends downward, and then the lateral epicondyle, plus it is also attached to the anterior surface of the shaft of the tibia, where the upper end ends. But this line ends here. Just lateral tibial velocity, fibrous structure is not continuous. Similarly, medially is attached to the superior surface of the medial epicondyle, then it is attached to the medial surface of the medial condyle, then it is also attached to the anterior surface of the shaft of the tibia, but it is also interrupted here. Fibrous capsule doesn't cross, not attached to the medial post. So there is an interruption line in the tibia. Superiorly it is also interrupted on the lateral and medial epicondyles. And there is a gap superiorly as well as anteriorly. It is because of the muscle. We know the anterior surface of the femur. It gives the origin of the muscle that is called vastus intermedialis. The medial surface will give rise to the origin of vastus medialis. The linea supra gives the origin of the vastus lateralis. And from above comes the rectus femoris. All these four muscles unite to form the quadriceps femoris. And this tendon of the quadriceps femoris, it runs in front of the lower end of the femur and the anterior surface of the upper end of the tibia, and it forms a very strong tendon which is marching downward to insert on the tibial tuberosity. So this is how the quadriceps femoris is inserted over the tibial tuberosity. So this is the lateral medial border of the tendon of the quadriceps femoris. This is the lateral border of the tendon of the quadriceps femoris. So this fibrous capsule anteriorly is attached to the lateral border of the quadriceps femoris. And similarly, fibrous capsule is attached to the medial border of the tendon of the quadriceps femoris. Hence, the joint is now closed. So here it is lying over the. So now we can't see the bones because now they are inside the fibrous capsule. So the same diagram if we see in the lateral view. So from the linea supra, the muscle comes that are the vastus medialis. From lateral posterior to the lateral and then anterior. Then from the anterior surface, vastus intermedialis. And from the linea supra, vastus lateralis take origin, skirts from the lateral surface of the femur, and it comes anterior medially, and all muscles, four muscles are fused to form the muscle is taking insertion into the tibial process that we quadriceps. Now this is a very stout tendon of the quadriceps, and we know the knee are having mainly the movements, the flexion and extension. So whenever there is a flexion and extension is there, so during flexion and extension what happens? The tendon of the quadriceps femoris, which is running anteriorly, the posterior surface of this tendon will have got the friction with the bone all the time when there is flexion and extension. So this posterior surface of the tendon quadriceps femoris will have the friction with the lower end of the femur and friction with the upper end of the tibia, because we know bones are the hardest tissue of the human body. So hard bone and the soft end. So with movement what will happen? The posterior surface of the tendon will be damaged and the joint becomes unstable. So in order to prevent it, the friction between this is sesamoid bone develops inside the tendon of the quadriceps femoris posteriorly. So this was the need of the hour. Why the patella developed? To prevent the damage of the tendon of the quadriceps femoris. The patella has to be developed. So that's why the patella develops, and this is a sesamoid bone. So patella is a sesamoid bone. There are so many sesamoid bones are there in the human body, but this is the largest sesamoid bone. And the word sesamoid means this bone is different from all the bones of the human body, because it has got the special features. Number one feature is that it develops in the tendon of the muscle. All other bones of the human body either they develop in the cartilage or in the mesenchyme or in the membrane as the clavicle develops. But this develops in the tendon of the muscle. So in order to see this bone, we have to cut the tendon. So it is hidden in the tendon. That's why the word sesamoid. Sesamoid means seed-like. As we have learned in the botany, there are two types of the plants in the universe. Ones they are the angiosperm, others they are the gymnosperm. So it is like the angiosperm. What are the angiosperms? In which the seeds are covered. And gymnosperm, the seeds are naked. So this is the sesamoid, means seed-like. The word sesamoid. Seed-like. As the pea is hidden in the legume, when you have to open the legume, then you see the pea inside the green one. Same is here. When you see the patella want to see, you have to cut the tendon of the quadriceps, open it, then you can see it. Then the second specialty is this, that it is a solid bone, there is no medullary cavity. All other bones in the human body, when you cut, they are hollow from inside. That is called medullary cavity, but it doesn't have one. Third and most important feature of the sesamoid bone is it doesn't have what the periosteum. All bones in the human body, they are covered by the outer layer, that is called the periosteum. Just though the periosteum like the osteoblast cell layer for wear and tear of the bone. What sesamoid bone is devoid of the periosteum. So these three features you have to keep in mind, and when he asks you what is a sesamoid bone, it develops in the tendon. Second, it has got no medullary cavity. Third, it has got no periosteum. So it develops here. And the posterior surface of this patella is covered by the smooth articular Similarly, the reciprocal surface of the condyles of the femur were also covered by the smooth articular cartilage. They are smoothly articular cartilage. Similarly, the upper end of the superior surface of the knee were also smooth because of the hyaline cartilage or the articular cartilage. So the condyles, they are all smooth. The smoothness is because they are stick with the articular cartilage anteriorly as well as posteriorly. So patellar surface is also smooth because it is cartilage, and the same patellar surface of the femur anterior surface will coincide with the patella. So this is how we show in the lateral view of it. Similarly, the superior surface of the tibia is also smooth. Again, it is smooth because it is covered by articular cartilage. So this is the prerequisite of the synovial joint. So then whatever bones are taking part and coming together, they are called articulation. So the movement should be frictionless. In order to make the movement smooth and frictionless, the touching surfaces of the bones of the joint, they are covered by articular cartilage, which is the hyaline part of the cartilage. So the lateral surface of the tendon of the bicep is fused with the fibrous capsule anteriorly. That's why fibrous capsule was interpreted here and here. Now the same fibrous capsule infiltrates in the posterior view. Then we see the also type of the medial condyle, and above the medial condyle, above the intercondylar area, and above the lateral condyle. Adductor tubercle is outside the fibrous capsule. It is not inside here. Adductor tubercle is outside the fibrous capsule. Then there is a continuous line of the attachment of the fibrous capsule posterior to the femur. And then the fibrous capsule then cover the medial surface of the medial condyle of the femur and the tibia. Then it attaches to the posterior surface of the medial condyle of the tibia. Similarly, the lateral part of the fibrous capsule also comes downward and attaches to the lateral condyle. But on the posterior surface of the lateral condyle of the tibia, again there is interruption. A gap is there. Interrupted, we have to make an interrupted line. So a perforation is there in the fibrous capsule, and this perforation is for the action of the popliteus muscle. Because this is the part of the popliteus has to become extracapsular. So while making the lines of the fibrous capsule attachment, one should always make the interrupted line and interrupted line anteriorly. So this is how we do the attachment of the fibrous capsule. Posteriorly, we can show from here the attachment and the fibrous capsule below attachment the posterior circulatory median. Now the synovial membrane is a very delicate membrane, and all the synovial fluid is secreted by it, and the synovial membrane is present on the inner aspect of the fibrous capsule. Inner aspect of the fibrous capsule. The fibrous capsule outside is there, but when we see the inside of the fibrous capsule, it is white and shiny. It is white and shiny only because it is covered by the synovial membrane, which lubricates the joint, and the synovial fluid is produced by it. So, the anterior surface of the tibia and the posterior surface of the lateral quadriceps, in order to prevent the friction, they are like the pad of the infrapatellar pad of the fat. So this gap is closed by the adipose tissue or the fatty tissue, and now the tendon doesn't touch the image. So we call the infrapatellar pad of the fat. Infrapatellar pad. Visible in the central section of the lateral view of the knee. So after joining these three parts, now we will discuss the ligaments of the knee. So like knee hip joint ligament, there are two types, that is the extrinsic and the intrinsic ligament, or intracapsular and the extracapsular ligaments. Now which are inside the fibrous capsule, these ligaments they are called the cruciate ligaments. And another is the transverse. Meniscal ligament. So cruciate ligaments, there are two in number, anterior and posterior. And these ligaments, they are called cruciate because they cross each other and they give the internal strength to the knee joint and prevent dislocation. The anterior cruciate ligament and posterior cruciate ligament, they are all attached to the superior surface of the tibia. In the middle part is called the rough area, that is called the intercondylar rough area. And in this intercondylar rough area, 6 structures they are attached. 6 structures they are attached. Out of these 6, 2 are the cruciate ligament. So anterior cruciate ligament anteriorly attached, and posterior cruciate ligament is attached the posterior part of the superior surface of the tibia. So if we see posterior superior surface of the tibia, it looks like this: large medial condyle and a small lateral condyle. They are not equal, and anteriorly there is the medial tuberosity. So they are both medial condyle and lateral condyle is smooth because of the articular cartilage, but the intercondylar area, this is rough area. Same intercondylar rough area of the femur also rough. So rough is the rough surface, and smooth is the smooth. So cruciate ligaments they are attached. So they cross each other. And the anterior cruciate ligament, posterior ligament, posterior intercondylar, and they cross it. So anterior cruciate ligament is attached to the anterior part here. In the intercondylar area, and posterior cruciate ligament is attached to the posterior part of the intercondylar area. So anterior cruciate ligament is attached to the anterior aspect of the intercondylar area, and then it goes to the lateral side and attaches the medial surface of the lateral condylar. To the intercondylar rough area of the femur. So anterior cruciate ligament is attached to the medial surface of the lateral condyle, and opposite is the posterior cruciate ligament. It is attached to the lateral surface of the medial condyle. So this is how they cross each other. And while a person is standing, these crucial ligaments they prevent the anterior and the posterior dislocation of the femur on the tibia. That's why they are crossing each other. Another very important shock absorbent mechanism in the knee joint is the presence of the fibrocartilaginous menisci. So there are two types of the menisci are there. One is the medial meniscus and the lateral meniscus. So they are lying between the touching surfaces of the lower end of the femur and the upper end of the tibia. So these are attached to the lower superior surface of the tibia, on which the weight of the femur is falling. So because of this, they become concave superior to accommodate the surfaces of the cartilages of the femur. The medial meniscus is larger because the superior surface of the medial condyle is very large. So the meniscus is large also and its shape is resembling the alphabet C. It is C-shaped. And their median end is having a resemblance with the horn of the sheep or the goat. That's why they call the horn of the medial meniscus, the anterior horn and the posterior horn. Otherwise, these menisci are attached to the rim of the superior surface of the tibia, attaching bone. And medially, there is the anterior horn of the medial meniscus, another is the posterior horn of the medial meniscus. And these menisci horn are attached to the intercondylar paraphernalia. And this is the superior surface is smooth, and this is also the smooth surface of the articular cartilage of the superior surface of the tibia. So this is the smooth area they are available. And if you cut with any meniscus, they are thin medially or at the center point, but at the peripheral part, where they are attached to the bone tibia, is thick. So therefore, it makes the superior surface a shallow concavity to accommodate the condyles of the femur, like the same area with the labrum acetabular. And the nutrition or the arterial supply of the menisci is from the peripheral surface. So the blood supply comes from the peripheral. The arterial restrooms around the knee joint give the branches which invade the fibrous capsule and they give the blood supply to the menisci on the peripheral part. So this is the region, whenever any menisci they are damaged and when we want to remove it, we only remove the medial part, central part. We leave the peripheral part. Menisci because we know it is the blood supply and they can regenerate. So we never remove the peripheral part of the meniscus. Then the lateral meniscus is smaller because of the small size of the lateral tibia. So the meniscus is also small and and it resembles the alphabet O. So it is O shape. And it is also the anterior horn and the posterior horn. This is attached to the intercondylar area. And this is the medial central surface. This moves like here also. So lateral meniscus is also having two horns, anterior and posterior, attached to the intercondylar area. So in this way, two horns of the medial, two horns of the lateral, and two cruciate ligaments. Six structures they are attached to the intercondylar rough area. So whenever we have to mark it, we make the 6 dots in the intercondylar rough area. And all these 6 dots they depict the attachment of the medial meniscus and the lateral meniscus as well as the cruciate ligament. And the sequence to remember is very, very important. That which comes in number 1, which is number 2, which is number 3, which is 4, 5, and 6. So this is a formula to remember here. The structure attached on the anterior to posterior side. The formula is the Medical College, Ludhiana Medical College. Or Medical College Lahore Medical College, one and same thing. And this formula is from anterior. So first M stands for the anterior horn of the medial meniscus. Then C stands for anterior cruciate ligament. Then L stands for the anterior horn of the lateral meniscus. Again L stands for the posterior horn of the lateral meniscus. Then M is the posterior horn of the medial meniscus. And last C stands for the posterior cruciate ligament. So this is how we have to remember throughout the life. This formula, Medical College Lahore Medical College. So these are the internal sections. Now the anterior surface of both these menisci, they are joined together by a ligament, which is called the transverse femoral ligament or transverse tibial ligament or transverse meniscal ligament. So anteriorly, the anterior bones of the lateral as well as the medial meniscus, they are fused with the transverse ligament. So the synovial membrane is attached to the medial surface of the fibrous capsule internally. So this is how you can show the synovial membrane. Posteriorly also, the posterior cruciate ligament is posteriorly covered by the synovial membrane. Then the synovial membrane, the suprapendular part, is attached to the upper border of the posterior surface of the patella. Then this synovial membrane is attached to the posterior surface of the pattern of the quadriceps femoris. Then this synovial membrane reaches as a convex and then it turns downward up to the origin of the vastus intermediaris from the anterior surface of the shaft of the femur. Then the synovial membrane is reflected on the anterior surface of the shaft of the femur and then attached to the upper border of the patellar surface of the femur. So it is reflected like this. A delicate membrane. So this synovial membrane attachment above the patella it forms a fluid sac. So it is called the suprapatellar bursa. So this is the suprapatellar bursa. This is suprapatellar bursa. Suprapatellar bursa is nothing but this is the reflection of the synovial membrane above the patella and above the patellar surface of the femur. There are chances that the synovial membrane may fall downward and may be crushed between the patella and the anterior surface of the femur. So a small muscle they take going from the anterior surface of the lower part of the shaft of the femur, and these muscles they are inserted over the convexity of the synovial membrane. These 1 or 2 or 3 slips, small slips of the muscle taken from the anterior lower surface of the shaft of the femur and inserted on the synovial membrane. They are called the articularis genu muscles. They are called articularis genu muscles. Genu means bend. So they are the small muscles. So the contraction of these muscles will always open the synovial membrane in upward direction in all movements of the knee joint and prevent its falling down, and crushing is prevented by these small but very important muscles. So these are the internal arrangement of the knee joint with the menisci, with the bursa, and with the cruciate ligaments. Now on the extracapsular ligament. So the extracapsular ligament here, as we mentioned, they are outside the fibrous capsule and they give the outside support to the knee joint. So out of these extracapsular, these are the number one, the medial or the tibial collateral ligament, the lateral or the femoral collateral ligament, then there is the oblique ligament, and there is the arcuate oblique ligament. So these ligaments they are outside the fibrous capsule and they fuse with the capsule, and some are not fused. So we will take one by one. First is the medial or tibial collateral ligament. So this we have already done when we were doing the adductor magnus muscle, whose ischial or the hamstring part is inserted on the adductor muscle just below the fibrous magnus. And we have mentioned at that time also that from the adductor buccal, the adductor magnus is not ending here, but its abdominal extension is coming downward, which is the hamstring part of the adductor magnus, and this abdominal extension comes downward and fused with the fibrous capsule, and it is attached to the medial surface of the medial patella of tibia. Medial surface of medial patella of tibia plus fibrous capsule. So this is the tibial collateral ligament or medial. It is nothing but this is the hamstring part of the adductor magnus. And it is fused with the fibrous capsule, and fibrous capsule in turn is fused with the medial meniscus. So medial meniscus is also fused with the fibrous capsule, and fibrous capsule is the tibial collateral ligament. So in the movements of the knee joint, so all the three structures they are fused together and they remain stationary. While the lateral collateral ligament, lateral meniscus is not attached to fibrous capsule. Then there is fibular collateral ligament, and the fibular collateral ligament is attached superiorly to the lateral epicondyle of the femur, and inferiorly is attached to the tip of the apex of the head of the fibula, or what is called styloid muscles of the fibula. So it is away from the fibrous capsule. So there is a gap between the fibrous capsule and the fibular collateral ligament. Now the fibular collateral ligament is a slender ligament, stout ligament, while the tibial collateral ligament is a ribbon-like, flat ligament. So the gap between the fibrous capsule and the fibular collateral ligament, the structures which are passing from here. So they are the artery and they are passing. So the arteries are the genicular arteries and veins. Inferior, lateral, genicular artery, vein and nerve, they are structures passing between the gap and the fibular collateral and the fibrous. The fourth thing is also the popliteus muscle tendon. The tendon of the popliteus muscle is the intracapsular, is separating the lateral surface of the lateral meniscus with the fibrous capsule and the fibular collateral ligament. So this is the tendon of the popliteus. So this is how we can explain the ligament. Now for the oblique popliteal ligament. Oblique popliteal ligament, as we have done in the hamstring, this is the extension of the semimembranous muscle. As we have seen, the semimembranous muscle is technically known as tendinosity, it is a ribbon-like muscle, and it comes behind the medial capitulum and medial line of the tibia and femur. And where it is inserted? Posterior surface of the medial condyle of the tibia. This is the insertion of semimembranous muscle. Again, this muscle is not ending here, but the apoptotic extension of this muscle. So this is a hole in the fibrous capsule. Posteriorly, this hole in the fibrous capsule of the knee joint. So now we can't see the condyles and the condylar and the cruciate ligaments, because all now fibrous capsule covering the posterior surface of the knee joint, but also from the floor of the popliteal fossa, except there is a small gap there. So from the semimembranous insertion, the apoptotic fibers, they run upward and laterally, and they are fused with the posterior surface of the fibrous capsule. As they run obliquely from the semimembranous extension, so this ligament is called the oblique popliteal ligament. Oblique popliteal ligament derived from the tendon of the semimembranous. If you lower at the lateral fibers of this oblique popliteal ligaments, the arc over the perforation of the fibrous capsule on the posterior surface of the lateral condyle of the tibia, and they are at the lateral part of the posterior surface of the lateral condyle of the tibia, like this. So they are arc-like. So they are that's why they are the arcuate popliteal ligament. So the oblique and the arcuate popliteal ligament. So this arcuate popliteal ligament gives the strength to the hole in the fibrous capsule, and this oblique popliteal ligament is also giving the strength to the fibrous capsule posteriorly. So it is protecting the fibrous capsule posterior. And lower one, it is the area from where the mobilus muscle comes, becoming extracapsular and is inserted over the soleal line of the tibia like this. So this is the mobilus muscle coming out of the fibrous capsule for the insertion along the soleal line. So this is why this, and when the muscle contracts, it moves. And there are chances that the fibrous capsule may tear. So in order to give the extra strength to the fibrous capsule whole, this articular coordinating ligament is fused with it. So that is the purpose of the ligament. So this is how we see the three-dimensional picture: the fibular collateral ligament to the attached here, and the tibial collateral ligament from the medial epicondyle fused with the fibrous capsule, and then attached to the tibia. So this is how we show the anterior and posterior aspect, the ligaments of the knee. So this is about the intrinsic or the extrinsic ligaments of the knee joint. Now another ligament is called the ligamentum patellae or the ligament of patella, which is a misnomer actually. Patella touches the posterior surface of the tendon of the bicep, the quadricep femoris, and the vastus medialis, the vastus brachialis, the vastus intermedialis. These muscle fibers, they cannot go beyond the base of the triangular sacroiliac bone. Beyond this part, only the abdominal muscles of these muscles they are coming downward up to the tibial tuberosity. So it looks like that from the apex of the patella, the tendon of the quadricep femoris is inserted over the tibial tuberosity, is the ligament of the patella, but actually it is the tendon of the quadricep femoris. So ligament of patella is a misnomer. So in otherwise it is also a ligament of patella. As we are doing the outside ligament or the extracapsular ligament, so it also may come as the what is called ligamentum patellae. Now we show it the lateral from apex of the patella up to the tibial. So this is what we have done: the bones, the attachment of the fibrous capsule, and the intrinsic and the extrinsic ligaments of the, or intra and the extracapsular ligaments of the knee joint, and then three-dimensionally. Now come the movements of the knee joint. So the movement of the knee joint is done by the various muscle. Is the hinge variety of the joint, and flexion and extension, two movements are there. But there is a very slight medial and lateral rotation is also possible. Slight medial and lateral rotation is also possible. Now main movements of the knee joint are the locking and the unlocking mechanism. Then we have to understand what is locking and the unlocking. So when the knee joint is seen like this, a person is standing, this is called a full extension. And this full extension is maintained and done by the quadricep muscle. And flexion of the knee joint is done by the hamstring muscles, as we have done. So hamstring muscles they bring the flexion at the knee joint, and the quadricep muscles bring the extension at the knee joint. So when a person is standing, it means the knee joint is fully locked. So locking causes the standing posture. Opposite is the flexion. So when a person who is standing, and if he wants to sit on a chair, then what will happen? There will be the flexion. There will be flexion. Or if a person is lying down in a supine position in the bed, and if you want to flex the knee, leg like this, again there is a flexion done by the hamstring muscles. So when a person is standing or lying in a supine position in the bed, the knee joint is locked by the quadriceps strong muscle. But when we want to make the flexion from the full extension, then the popliteus comes, and the popliteus will unlock the joint, and then the hamstring will act and the person can flex the leg. Similarly, in the standing posture also, when a person is standing, quadriceps is making the full extension of the knee joint, and it is locked. But if a person wants to sit on a chair, then what will happen? Popliteus will unlock the knee joint. In the standing posture also, only after that the hamstring will act and the hamstring will bring the sitting posture of the person. So popliteus is the key muscle of the knee joint. It is a key which locks and unlocks the knee joint. That's why it is called the key muscle. So the popliteus muscle is very important to understand its origin and insertion. So this popliteus muscle is special muscle. Everything of the popliteus muscle is special. What means its origin, its insertion, its nerve supply and its action all are special. What is speciality of the origin? Number one, speciality of the origin is that its origin is tendinous, cylindrical, small. And what is the speciality of the insertion? Its insertion is fleshy, thick. It is opposite to usual muscles. Then what is the speciality of the nerve supply? This muscle is supplied by the tibial nerve, a branch from the tibial nerve in the popliteal fossa below. What is the speciality of this branch? Its course. So, after the origin of the nerve popliteus from the tibial nerve in the popliteal fossa, this nerve running downward and laterally, and runs on the posterior surface, reaches the posterior surface of the popliteus. Then it reaches the lower border of the popliteus, and then it winds down its lower border, skirts down its lower border, and then it enters the anterior surface of the muscle and then supplies it. That we have to remember. The course of the nerve popliteus is very important. It is special. It can enter directly here also to supply the muscle, but no. First it runs on the posterior surface of the popliteus, then reaches its lower border, and then it skirts around the lower border, skirts around its border, and then gains its anterior surface and then supplies it. So then we have to write down whenever a question asks the nerve popliteus is special of its course. Exactly in these words you have to write down, then you get the marks. Then action. Action is also special. I have told you that it is a key muscle of the knee joint. So locking and unlocking is done by this muscle. Small muscle but very important muscle in this standing posture, and this is the only muscle which makes us sit on a chair and lift from the chair to a standing posture. So how this mechanism is there? So movement of the knee joint means locking and unlocking mechanism of the hinge variety. So origin of this muscle is very, very important. So the origin of this muscle is from the lateral condyle of the femur, not from the lateral surface, but it takes origin from the anterior surface of the lateral condyle of the anterior surface of the lateral femur, when a groove is present on the lateral surface of the lateral epicondyle of the femur, there is a groove. So then this muscle from the origin from the anterior part of the lateral condyle, this tendon then runs posteriorly and lateral, and there is a groove present already below the lateral epicondyle of the lateral surface of the femur. So this tendon goes into this, it is fitted into this groove. After that, and this origin is intracapsular. So original specialty, number one, it is tendinous, and number two specialty that it is intracapsular but extrasynovial. This word I have already done. Intracapsular and extrasynovial. Same thing we are using these two words for the upper limb also when we were doing the origin of long head of the biceps. From supraglenoid tubercle, again, that was also intracapsular and extrasynovial. And bicep tendon, long head of the bicep brachii is also tendinous. Same is the copious in the lower. You have to remember. So after taking origin from the anterior part of this lateral condyle, the tendon is inside the fibrous capsule but outside. Then it comes posteriorly from the groove of the lateral condyle, and posterior there it comes and comes outside the fibrous capsule below the articular. So this is the course of the tendinous origin of the origin, and here it comes. Now see in such a flexion, broad. So this is the how it progresses from the anterior surface of the lateral condyle. So what will happen? So whenever this muscle will contract, so what will bring out? The lateral condyle of the femur is, or the lower of the femur is rotated laterally. So that's called the lateral rotation of the femur. We can do the lateral rotation of the femur. Another specialty here, this muscle can act from both the sides. It can act from the insertion as well as it can act from the origin, depending upon the position of the lower limb or what is how you keep the locking and the unlocking muscle. So first now comes the. So today we will do the applied anatomy of the knee joint. So knee joint is a weight-bearing joint, and the most common problem of the knee joint is the after the age of the 40 years. Patients suffer from the pain in the knee joint, and this pain in the knee joint is because of the formation of the osteophytes. So osteophytes, they are this new bone formation either at the lower end of the femur or at the upper end of the femur, upper end of the tibia. So small bone formation, they start formation, and these small osteophytes, they bring about the friction whenever there is a movement of the knee joint, and this friction will bring the pain on the patient. Another pain cause is the thinning of the menisci. So median and the lateral meniscus, they becomes thinned out because of the uses, and this thinning of the cartilages, that is the menisci, brings about the the femur and the tibia, they becomes very, very close. and the movement is restricted because of the diminishing or the due to the less space between the knee joint. Between the lower end of the femur and the tibia, the space decreases due to the thinning of the menisci, and that may lead to the restricted and painful movement. Another cause, it may be because of the thinning of articular cartilages. So articular cartilages, as we know, they cover the smooth articular surfaces of the femur as well as the tibia. But tibia is already having the menisci. So mainly the articular cartilages covering the lower end of the femur, they are damaged. They thinned out, and there are patchy or small areas where the articular cartilage is damaged or degenerated and underlying bone is exposed. So when this bone will strike against the bone of the tibia, then the patient suffers from the pain, as well as there is a swelling of the knee joint because of the accumulation of the fluid inside the knee joint, and the movement is restricted in this way. So that we have to do in the applied anatomy related to this. Then, so patient come with the complaint of the restricted movement of the knee joint, and because of the weight bearing, there is a painful condition is there. Another problem with this, usually it is common in the sports injuries, is the tear of the menisci. So medial meniscus is more injured during the rotational movement of the sports injuries. As we know, the medial collateral ligament is fused with the fibrous capsule, as well as it is fused with the medial collateral ligament with the fibrous capsule, as well as the medial meniscus. So during rotational injuries, what happens? This medial meniscus becomes stationary, while the lateral meniscus is away from the fibrous capsule and the fibular collateral ligament. So because of this fusion of the fibrous capsule, medial meniscus and medial collateral ligament, so there comes the tear of the medial meniscus. And medial meniscus is having this type of the tear may be there, and this tear is called the bucket handle deformity. Bucket handle deformity of the medial meniscus. So there is a tear in the middle, and this causes the restricted movement of the knee joint and painful movement of the knee joint. So in this case, we do the operation, the surgical operation, and we remove the medial part of the meniscus, but we keep the lateral part of the meniscus as such. As we know, the blood supply of the meniscus is from the periphery, so it regenerates and it becomes normal. Another problem of the menisci is sometimes a small piece of the meniscus is detached from the lateral or the medial meniscus, and this small piece of the meniscus later on undergo fibrosis and calcinosis, and this increases in size, and it is also called the white mouse of the knee joint. It is called the white mouse of the knee joint, and this white mouse, small piece of detached cartilage in the knee joint, it floats in the synovial fluid, and in sometimes this small mouse may come between the lower end of the femur and the upper end of the tibia. So because of this, at once the movement of the knee joint is restricted in the position, maybe in the mid flexion or in the full flexion. So because of the foreign body. So again the treatment is surgical, and in the surgical treatment we remove this white mouse, and when we do the operations on the knee joint, we do the anterior approach. So we always go from the front side, because we know posteriorly there is a popliteal fossa and many vital structures are there. So whenever we have to do the surgical procedures, we do from the anterior. Either we do to remove the osteophyte, we put the arthroscope, that is called the arthroscopy. So it is the instrument we put from the front side of the knee joint, and we visualize the inside story and the cartilages and everything of the vein. Or when we can remove the osteophytes also from the same instrument, and patient can become the pain free. So that is called the arthroscoping, and arthroscope is used for knee joint maneuver. Another problem with the knee joints is the damage of the menisci, as well as the damage of the articular cartilages, and damage of the and formation of the multiple osteophytes in the knee joint. And because of all these conditions, patient becomes crippled, and the movement of the knee joints, bilateral or unilateral, becomes restricted. Usually it is bilateral, so the movements are restricted. In these cases, we advise the patient to go for the TKR. So TKR is the total knee replacement operation. So in this operation, what we do, we remove the articular surfaces of the femur with the patellar surface also. So we remove the lower end of the femur, as well as we also remove the upper end of the tibia. And instead of these pieces, we fit the already purchased, available in the market, the prostheses of the lower end of the femur as well as the upper end of the tibia. So this is how we show that the lower end of the femur is having a steel prosthesis. So it looks like exactly like the lower end of the femur. Similarly, the upper end of the femur, the tibia is also removed, and it is replaced by so upper end this is made of the plastic material. So it is again the prosthesis. So it is also available in the market. So we remove this, the upper end of the tibia, and we fit this upper end of the prosthesis of the tibia like this. So it also looks like the upper end of the tibia. So this operation is called the TKR, in which we have removed the damaged articular cartilages and this structure. So that operation is called the TKR operations. Another problem of the knee joint is affected by many infective problems, and these infective problems, they are the infective arthritis. So because of the infection of the knee joint, the pus is accumulated in the knee, and this patient comes with the pain and the swelling in the knee joint. And in order to remove the pus, we again go for the anterior approach of the knee joint. Another problem of the knee joint is the fracture of the patella. Patellar fracture. As you know, patella forms a joint also with the knee joint. That is the tibiofemoral joint is the knee joint. Another part of the knee joint is the patellofemoral joint. Patellofemoral joint. So patella articulates with the lower end of the femur, and we know the patella is a sesamoid bone. It is a triangular structure develops in the tendon of the muscle, and this patella is also involved in the affection of the knee joint. One is called the recurrent dislocation of the patella. So in some people, recurrent dislocation of the patella occurs. It is because the posterior surface of the patella is having a large lateral and a small medial articular facets, which closely resembles the same reciprocally, the same surface, the patellar surface of the femur, which is having large lateral and small area. So patella is also having the same affection here. It has got a large lateral and a small area. But in some people, this large area becomes more larger, and because of this, there is a dislocation of the patella occurs in some individual. That is the recurrent dislocation. Another problem of the patella is the stellate fracture. So stellate fracture, as the name suggests, stellate means star shape. So whenever there is a front impact, the knee joint, the patella is fractured like this. So this is called the star-shaped fracture. That is called the stellate fracture of the knee joint or the patella. As we know, it is a sesamoid bone. It has got no medullary cavity, and it has got no periosteum covering it, and develops in the tendon of the quadriceps femoris muscle. So small fragments are there, but these fragments, they are very close together. Even after the fracture, there is no displacement because they lie in the tendon of the quadriceps femoris muscle. So they remain as such in their anatomical position. So the treatment is again the surgical. Here we put a wire inside the circumferential wiring is there. So steel wire is there, and we put the wire circumferentially in the patella, and we all the fragments, they are again fused together. So that is how we treat the patellar stellate fracture. So this operation is called the open reduction. We open the patella and circumferential wiring is done. Circumferential wiring and open reduction is the name of the surgical procedure we adopt for this, what is called the stellate or star-shaped fracture of the patella. Sometimes what happens, there is no star-shaped fracture is there, but there are a large area and small fracture may be there. So in this case, we remove the smaller piece of the patella and we retain the larger one. So that is also the sometime in cases of the unequal fractures, fragments may be coming. But if it is stellate fracture, in the stellate fracture, all the fragments, they are comminuted, or they are very, very close together. So this fracture is also called comminuted fracture. Comminuted fracture of the patella, that is the stellate fracture, in which all the fragments are there, but they are present even after the fracture in the anatomical position. Another condition related to knee joint is the heme arthrosis. So heme arthrosis is the condition in which there is a blood collection is there in the knee joint cavity. It is usually occurred in the patients who are suffering from the bleeding disorders, or it may be traumatic also. In the roadside accident, if any blood supply or blood vessels supplying the knee joint may be ruptured, and these lead to the collection of the blood inside, and that blood is clotted. And this clotted blood will bring about the restriction in the movements. Again, we do the anterior approach of the knee joint and we remove the hematoma and blood from the knee joint to free it all, the structures. So these are the conditions that are related to the knee joint. Thank you.